The discharging ear is not a diagnosis, it is a symptom. Take into account what the patient tells you in the history and how the ear looks. The ear canal is a self-cleaning system. Disruption of its pH, moisture balance or epithelial barrier often sets the stage for otitis externa. Otitis externa is the most common cause of ear discharge and is best understood in three clinical forms: acute, chronic and necrotizing. Acute otitis externa often has a short history, is painful and often bacterial. Chronic otitis externa is often relapsing, itchy and associated with skin conditions. Necrotizing otitis externa is rare but serious, affecting diabetics and elderly with disproportionate pain and potential cranial nerve involvement, such as facial weakness. Other important differential diagnoses include chronic suppurative otitis media, especially in children, cholesteatoma, which can be destructive, persistent, and often smelly, mastoiditis, which can be identified with postauricular swelling and tenderness, foreign bodies and trauma, common in children.
Level 1 management of the discharging ear is with community healthcare workers who are able to focus on early recognition, education, and safe first-line advice such as dry ear precautions or suggesting vinegar alcohol mixes if the eardrum is intact. Community healthcare workers can follow up cases or refer promptly if there are concerns such as persisting symptoms, hearing loss, or systemic illness. Level 2 management is with clinicians who can differentiate between bacterial, fungal, allergic, and more complicated causes. They can examine the ear with instruments such as an otoscope or video probe and recommend topical drops tailored to the suspected organism and the tympanic membrane status. Clinicians need to be aware of pitfalls such as using ototoxic drops when the tympanic membrane status is uncertain and overprescribing systemic antibiotics. Clinicians should escalate if there's no response to their treatment within 7 days or complications arise. Level 3. Ear, nose and throat surgeons and clinical officers are able to focus on a precise diagnosis, give microbiological confirmation, and aid management of refractory cases and complications. They have access to microsuction, wick insertion, imaging, and potentially culture-guided therapy. Surgical skills include meatoplasty for canal stenosis and operative care for necrotizing otitis externa or cholesteatoma.
To recap, red flags include persistent discharge despite appropriate therapy, cranial nerve signs or severe pain out of proportion with examination, a history of diabetes or immunosuppression, recurrent otitis externa not responsive to conservative treatment measures, as well as foul smell, granulation tissue, or facial swelling. Every healthcare worker, from the village clinic to the operating theatre, plays an important role in preventing ear disease complications. When we act early, treat wisely, and educate about health conditions, we're not just clearing infections, we are protecting hearing, preventing surgery, and improving quality of life.